Hello, welcome to Psychology Network 101. My name is Jean Shi. Today we will be looking at a case of a girl named Sophia Pak with body dysmorphic disorder. Sophia looks like every other college student, except there's one thing different about her. She deals with a distressing disorder every day. Let's take a look.
Hi, I'm Sophia Pak, and the problem began a few years ago when I had acne, and eventually the acne cleared up, but it left a lot of scars, and I didn't want to see people because I thought they'd see the scars on my face first. And if you can see now, there's still like a bunch of scars on my face, and I want to get rid of it, but I just it's been such a struggle. Like, I don't know what to do. I honestly I really hate it. Like, it's destroyed my self-confidence.
Today we will be hearing from a leading psychologist in this field. Her name is Cindy Chu. She will be joining us over webcam.
Hi Jean, I'm so excited to be with you all. I think Sophia is a classic example of someone who has body dysmorphic disorder, and I'm excited to share with you all things that I've researched over many, many years. Let's take a look at what body dysmorphic disorder actually is. Body dysmorphic disorder is an under-recognized psychological disorder defined as a preoccupation with some imagined defect in physical appearance or a gross exaggeration of a slight physical abnormality. This preoccupation is extremely distressing to the individual and can cause significant impairments in psychosocial functioning, especially because BDD preoccupations are time-consuming, occurring an average of 3 to 8 hours a day. An estimated 0.7 to 1.7% of the general population has BDD. Most researchers suggest that BDD begins in adolescence because there is the most concern over social and physical development. People with BDD are constantly preoccupied with an imagined defect. They most frequently dislike aspects of their face or head, specifically acne, scars, or wrinkles on their skin, excessive body or facial hair, and certain features of the nose. Their imagined ugly defect leads to an extreme anxiety in social situations. Individuals with BDD try to find ways to avoid full exposure of their appearance in public. Many sufferers of BDD also deal with compulsive behaviors in order to examine, improve, or hide the imagined defect. Many times this looks like excessive washing and mirror checking. In addition, those with BDD frequently suffer from shame, anxiety, depression, and low self-esteem. BDD shows a high comorbidity with major depressive disorder, social phobia, and obsessive-compulsive disorder along with substance abuse. Major depressive disorder is most frequently comorbid, occurring in about 75% of people during their lifetime. In addition, 2 separate studies have shown the prevalence of suicide attempts is 24 to 29% for those with BDD. Let's now take a look at the etiology of body dysmorphic disorder. Biological theories of BDD focus on serotonin dysregulation and neurological disturbances because studies have shown that patients seem to respond to SSRIs. Studies have also suggested that BDD results from temporal lobe disturbance, which produces a sensation of swelling passing through an individual's body in such a way that the person actually feels that the body has become distorted and believes it to be true. Studies using fMRIs have also suggested that there are neurobiological factors contributing to BDD. In one study, those with BDD demonstrated abnormal relative hypoactivity in areas of the brain for low detail images and abnormal relative hyperactivity in systems for high detail images. Such neurobiological functioning could explain the way individuals with BDD focus excessively on details. Other studies have shown that 8% of individuals with BDD have a first-degree family member with a lifetime diagnosis of BDD. This is 3 to 8% more than the general population. One study indicated that abnormal processing of semantic information could explain the biased processing of general knowledge in BDD. For example, in one particular study, BDD patients misinterpreted other emotions as being angry. Other studies have examined the neurocognitive functioning in BDD. For example, when BDD patients were presented with a visuospatial task and instructions to draw the figure, those with BDD tended to focus more on details. This may be another indicator of an imbalance in detailed versus holistic processing, which can explain the tendency for individuals with BDD to overfocus on minute flaws. One psychological factor that may contribute to BDD is a high level of negative affectivity. People with high negative affectivity have a general negative condition encompassing anger, a sense of rejection, guilt, and more. We can also examine BDD in the context of classical conditioning. Negative events involving one's physical appearance, such as teasing during puberty, could have been an unconditioned stimulus that resulted in a negative emotional response, such as shame. Lastly, we can look at BDD through operant conditioning. Those with BDD may have compulsive behaviors in order to reduce short-term distress. This would be an example of negative reinforcement. It is widely held that cultural factors play an enormous role in the development and maintenance of BDD, especially cultures that emphasize the importance of appearance and physical attractiveness. Such a culture leads to comparison with others or an idealized standard of beauty. There is also preliminary evidence that sexual, emotional, and physical abuse in childhood may be associated with BDD. One study found that 38% of 50 BDD patients reported some form of abuse during childhood. Previous research testing the negative verbal commentary on a person's body image has indicated that specific teasing about weight or size was also a significant predictor of body dissatisfaction. The following are 5 methods of assessment to diagnose body dysmorphic disorder. The body dysmorphic disorder examination is the most widely used because it was designed to diagnose BDD and to measure symptoms of severely negative body image. It includes both a structured interview and questionnaire. Now let's examine the maintenance of body dysmorphic disorder. Very few studies have examined the course of BDD, especially because BDD was only added as a disorder in the 1980s. The most recent one, published in 2012, examined the 4-year course of BDD in 166 individuals. More severe BDD symptoms at intake and a longer lifetime duration of BDD predicted a lower likelihood of full or partial remission. Contrary to the researchers' hypothesis, greater delusionality of BDD beliefs and comorbid major depressive disorder at intake did not significantly predict a lower probability of BDD remission. In addition, an earlier age of BDD onset predicted the probability of full or partial relapse. Ultimately, this study showed that BDD tends to be chronic, with a low probability of full remission and high probability of relapse. Now let's take a look at treatment. Many people resist a diagnosis because they believe they are truly flawed, and surgery or dermatologic treatment is the solution. They do not understand their worries are the result of a treatable mental illness. Currently, psychotropic medications and cognitive behavioral therapy are considered the primary treatments for BDD. The cognitive behavioral therapy model proposes that individuals with BDD are likely to overfocus on imagined defects and attach significant meaning to them or consider them very important. CBT, cognitive behavioral therapy, typically begins with psychoeducation. This is when the therapist explains and individualizes the cognitive behavioral model of BDD. Then CBT includes techniques such as self-monitoring one's automatic negative thoughts and behaviors, cognitive restructuring, exposure therapy, particularly to avoid social situations, response prevention, and relapse prevention. Medications for individuals with BDD must be tailored to the individual because each patient will differ in terms of comorbidity, past treatment, tolerance of side effects, and more. Serotonin reuptake inhibitors, SSRIs, are currently considered the medication of choice for BDD. Available data has shown that SSRI treatment significantly improves BDD symptoms. Many clinicians also believe SSRIs can make it more feasible for severely distressed patients to tolerate CBT. Many BDD patients seek non-psychiatric treatment, such as surgery and dermatologic treatment. Most professionals argue against surgery for those with BDD because of the potential for bad outcomes, including dissatisfaction with the surgery. The most common treatment outcome in one particular study indicated no change in overall severity of BDD symptoms. Many think that BDD is a variant of obsessive-compulsive disorder. However, there are important differences. Individuals with BDD tend to have poor insight, higher comorbidity with major depression, social phobia, psychotic disorder diagnoses, and a higher suicide attempt rate. Thus, BDD is a unique disorder and should be recognized as such. In the past, BDD has had psychotic and non-psychotic variants classified as separate disorders. The psychotic variant was considered a delusional disorder, while the non-psychotic was a somatoform disorder. Delusional BDD patients were more likely to have attempted suicide, have poor social functioning, and have more severe BDD symptoms. However, some researchers believe a dimensional approach using a spectrum of insight better reflected body dysmorphic disorder. There have been some changes in the DSM-5 regarding BDD. A diagnostic criterion describing repetitive behaviors or mental acts in response to imagined defects has been added to the DSM-5. The delusional variant of body dysmorphic disorder is no longer coded as a different disorder. Instead, DSM-5 added an absent insight and delusional beliefs specifier. In addition, a with muscle dysmorphia specifier has also been added because there has been clinical utility of making this distinction.